So yeah, so like I won't say this is going to be just like a class which would be only focusing on the important things, but this is also going to address the basics of like everything regarding dementia, like pathophysiology. So we'll go into the basics and depth of the thing, so that it is like so that it just remains for a longer time period of time in our memory. So yeah. So let's start. So dementia, this is the definition from ICD-11. Dementia is a condition where there is significant decline in at least two cognitive functions compared with the person's previous level and what is expected of their age. So there are two, three things that it says: at least two cognitive functions, and same is described in DSM, I think, DSM-5, and the previous level of functioning should be impaired as and as expected of their age. So this is important. And then we have memory is usually that is very commonly affected. And other cognitive functions that may be impaired include executive functions, attention, language, judgment and social cognition, psychomotor speed, and visuospatial and visuoperceptual abilities. We'll go into the details of these when we would be looking at the clinical features, as well as while we are differentiating different types of dementias. For example, reversible dementia from irreversible, subcortical dementias from cortical dementias, etc. All right. So, moving on, the impairment must be confirmed by two things: history from the patient, family informant, or clinical observation. And second thing is objective evidence on cognitive testing. So, can any one of you name any cognitive tests that, like neurocognitive batteries that we use for assessment of patients with some neurocognitive deficits?
Yeah, there is the MOCA test and there is
Okay.
MMSE
Mm-hmm.
and
Yeah. Anyone else? We have ACE3
Yeah,
and
yeah, the cognitive.
yeah. And then
Yeah,
we
we can
have,
use the mini mental state as examples as well.
yeah. Anything else? So how do we do frontal lobe examination? Like, what is the name of that battery?
the frontal lobe assessment battery, right?
Yeah, yeah, that's right. So some of the most commonly used neurocognitive assessment scales are these. So these are two things. So first thing is impairment must be confirmed by the history from the patient, family informant, or clinical observation. And the second is objective evidence on cognitive testing. So these are the two things. And then we move on to behavioral or personality changes can be present. Sometimes even the first symptoms in some dementia. Can you name one type of dementia that can present first as behavioral or personality change rather than memory deficits?
Maybe
Um,
language or yeah, or executive. Yeah.
sorry. Yeah, can you please repeat that? Are you
Yeah, I
able
think
to see my screen?
yeah,
Okay,
I think
great.
the speech, maybe the changes in a speech or ability to plan or organize things is the
Yeah.
first.
Yeah, that would come under cognitive deficits, the cognitive deficits of dementia. But my question is, like, is there any? So it says behavioral personality changes. What it says is, such as what are the changes that it mentions is irritability, agitation, disinhibition, or any type of personality change that may occur and can even be the first symptom in some dementia. So my question is, can you name one type of dementia where personality change is usually the first symptom rather than memory or cognitive deficits?
It's the frontotemporal dementia.
Yes, that's correct. Yeah. Okay. So the next one is the cognitive decline should not be due to any of these causes. That is, delirium, reduced consciousness, substance intoxication or withdrawal, stroke, seizures, traumatic brain injury, medications, or another psychiatric disorder. This could be any of these. Now, this is how you can. I don't think we need this because we already read this, but if you want to remember, you can use this. So, two declines in two or more cognitive domains, and confirmed by two things: history and cognitive testing. Global, yeah, this is also important, which is not written here. Which this is very important that global functioning is impaired. That is, activities of daily living are impaired in dementia. And O is for other causes excluded. So these are these causes. And S stands for social or behavioral changes may or may not be present. Late stages of dementia, social behavioral changes are present. In early stages, it may not, except for frontotemporal dementia. All right. So this is the definition directly taken from CTP. Sorry, this is the note. Yeah, okay. So, okay, can anyone tell me who introduced the term dementia?
You mean the name of the psychiatrist?
Yeah, yeah, right.
I think, yeah, I think that's the Doctor.
Yeah, I know
If
it's a
I'm
very,
pronouncing Alois, yeah,
sorry, which one?
Dr. Alois, if I'm
I
not
think,
wrong.
yeah, so Aloy is actually termed Alzheimer's dementia, not the term dementia. Like, well, term was given by, I don't remember the name, but it was very old. It is a very old term, which was given in some century BC. But it was introduced as dementia, like properly, by this guy who's a French physician, Philippe Pinel. I don't know if I'm pronounced Philippe Pinel. I don't know if I'm pronouncing him right. He was a French physician. So dementia term was introduced by Philip Pinel in 1789, and there are three very important defining features in dementia. This include decrease in multiple cognitive domains with a chronic course, impairing activities of daily living. That's it. Okay. Now, moving on to the pathophysiology of dementia. Let's just brainstorm things that can happen. Why dementia occurs? So, how about like we just brainstorm it first and then we go into that? So, like any one of you, what are the things? There are multiple causes for dementia. So, what are various causes of dementia? And then we can look into that. First, let's just do this. Or pathophysiology or etiological factors, whatever you can say. Anyone? Guys, are you with me?
I think I need to get out and back again. I have some connection issues. Is that okay?
Yeah, it's all right. It's all right. Yeah. Also, Dr. I'll just call you Dr. Ahmed. Dr. Ahmed,
Yeah.
yeah, I have made you co-host because I'm using this screen and I have to like I can't go back and forth from in the Zoom meeting and then back to the because I'm using the same like I have a tab that I'm using. So
Yeah.
if there is like someone in the waiting room, could you just let them in?
Yeah, sure.
Yeah, great. So, yeah. Any guesses on the causes, etiological factors, and pathophysiology of dementia?
Like the things I can remember are the neurodegeneration, like
Mm-hmm. Yeah. And how does this neurodegeneration usually happens?
I guess it's the accumulation of some proteins and in the neurons, like the tau protein, and also accumulation of neurofibrillary tangles,
Yeah.
amyloid plaques. These are the changes that I'm
Eh,
aware of in the Alzheimer dementia and some other types of dementias.
Yes,
But
yes,
it
you're correct.
depends on the type. And there are also the reversible causes of dementia. I'm not sure about the pathophysiology, though. How about that?
Yeah, wonderful, wonderful. So, yeah, you're right, you're right. So, neurodegeneration happens because of the accumulation of these proteins. And these proteins are actually accumulated because of a lot of factors. First is, well, age, increasing age. There can be mutations in the genes, sporadic mutations in the genes, which can, which you remember, if you remember,
Yeah,
ApoE4.
the
This is the
ApoE4,
ring.
right? ApoE4.
Yeah.
Yeah.
Yeah, and then even people who are predisposed to this, we have genetic predispositions already, which include other familial genes, which we would like with presenilin 1, 2, and APO, like APP. So we'll look into that later. So this is one reason that there is accumulation of these things. There are other reasons as well which can lead to dementia progressing. So let's just look into that pathophysiology of this of that. Okay. So
Okay.
yeah. So here we go. So we have age. We have we have genes which we already discussed. Then there are vascular risks. So in case of vascular dementia, we have vascular dementia, vascular risks. So central, what happens is cerebral hypoperfusion, which leads to decreased oxygen and glucose, and therefore neuronal death or neuronal degeneration, leading to executive dysfunction and slowed cognition. So, with age, what happens? So, this is what is written here. With age, we have decreased neuronal repair, decreased synaptic plasticity, reduced mitochondrial functions, increased oxidative stress, increased protein aggregation, and increased neuroinflammation. So, all of this happens with increasing age. And this is one more reason that increasing age is a predisposing factor for dementia. Okay, and what happens next? So let's say with increasing age, with genes, with vascular risks, whatever. Now, well, normally what happens is their proteins are folded correctly and abnormal ones are discarded by ubiquitin protease synthesis system. So ubiquitin tags like it tags the proteins and then they are discarded that this protein is not good. Let's just get rid of it. But with aging and genetics, they start to aggregate because ubiquitin system is not functioning well. So what happens is there is abnormal protein aggregation with this abnormal protein aggregation. And these are the proteins which are usually, as you already mentioned, you mentioned tau, you mentioned amyloid, and we have alpha synuclein and TDP43. There are others as well, but these are the major ones. So, what we see in Alzheimer's are amyloid and tau protein aggregation. In Lewy body dementia and Parkinson's dementia, alpha synuclein is most commonly seen. In FTD, TDP43 is seen, but not just TDP43, you have tau variant as well. So FTD also has tau protein aggregation. So yeah. Then what happens next is, well, when there is protein aggregation on the neurons, then it is going to activate microglia, which will release, well, inflammatory factors or and cytokines. These include interleukin beta, interleukin 6, TNF alpha, and of course, reactive oxygen species, which will lead to neuroinflammation and oxidative stress because of reactive oxygen species. And also, well, with oxidative stress, there will also be mitochondrial dysfunction, well, decrease in ATP, increase in oxygen free radicals, and therefore energy failure and neuronal dysfunction. So multiple factors play a role here. There are multiple hypotheses. This is one of them. This is one of the hypotheses that is leading to problematic problems in the dementia or clinical features of dementia. Then, what happens next with this is we have synaptic dysfunction. This is the earliest event. This is what Stahls say. So, Stahl psychopharmacology says that before neuronal death occurs, there is synaptic dysfunction that occurs because of all of this that is happening due to decreased dendritic spines, impaired CTP, decreased neurotransmitter release, and loss of synaptic connectivity. So, synaptic dysfunction is nothing but basically disconnection between different circuits or lobes of the brain. So this is what is happening here: synaptic dysfunction. Then the next thing is not only synaptic dysfunction, not only does disconnection, synaptic dysfunction does not only represent disconnection, it also represents, well, neurotransmitter dysfunction. So there are two things: there is dysfunction of neurotransmitters, and there is also deficiency of neurotransmitter. So we know that. Okay, I have a question here. It's already here. So what is the origin of acetylcholine? Like, where does it originate from? Which part of the brain or which nucleus? Anyone? This is a question of paper A, not of paper B.
Yeah, it's a paper A question actually. I'm
Yeah.
trying to remember. Yeah. Is it the nucleus basalis of minaret?
Yes, yes, you're correct. Absolutely. So very, very good. Oh my God, you're great. You remember it.
I've just taken
Awesome.
it. That's right.
Okay, so origin is nucleus basalis of Maynard, and well, there is degeneration of cholinergic neurons from this nucleus. So basically, neurons present here are degenerated, and the location of these is in cortex and hippocampus, which leads to we need acetylcholine, decreased production of acetylcholine. With decreased acetylcholine, there is impaired attention, learning, and memory. So this is another hypothesis you can say. So we have already seen the genes playing a role, because of which we have abnormal protein aggregation. Then um, we have vascular risks leading to all of the problems here. And we have also neurotransmitter deficiency, specifically acetylcholine, because of degeneration of cholinergic neurons here, which is also leading to the same thing. Now, other neurotransmitters working here are dopamine, serotonin, and glutamate. So dopamine also decreases, and it leads to apathy, slowed thinking, and movement disturbances. So this is why this is so if dopamine decreases, these are the symptoms that will come in. Then with decrease in serotonin levels, there are behavioral changes that are seen in this patient. Also, decrease in dopamine will lead to Parkinsonism like symptoms. So, Parkinsonian like symptoms, and that is why Parkinsonism. Then we have glutamate excitotoxicity. So what happens here is glutamate increases. With increase in glutamate, there is, well, hyperactivation of NMDA receptors on which glutamate binds. There is more inflow of calcium. More inflow of calcium damages the neurons. This is known as excitotoxic effect, and therefore the neuronal damage happens, leading to, well, of course, problems in memory and other areas wherever the neuronal damage is taking place. So this is it, and this is the basis. So we have two bases here. We are already, like, this helps us understand the basis of use of some drugs in dementia. So the first one is over here. Sorry, it's very much crowded. So because we want to have like balanced or increased levels of acetylcholine, and that is why what are the drugs that we use in dementia? Anyone?
Can you say it again, Dr. Spinach?
Yeah, you can call me Palak. I'm sorry, that's my, like, my
Oh,
YouTube
that's the
name.
last one. Oh, YouTube. Sorry.
It's all right. Okay, so my question is, because we understand now that there is decrease in acetylcholine, and that is leading to problems, impaired attention, learning, and memory. So this makes a basis of some of the drugs that we give in dementia. So could you tell me what are the drugs that we give and what is the mechanism of action of those?
So they are the acetylcholinesterase inhibitor, like
Yes.
donepezil, rivastigmine, and galantamine.
Yeah, you're right. You're right. All of them. So donepezil, galantamine, rivastigmine. So this is what we give. Now, another question over here, because because glutamate is like acting on these receptors, NMDA receptors, and then of course there is a lot of inflow of calcium leading to excitotoxic effect on the neurons. So we want to do something over here as well, which becomes the basis of another drug that we give in dementia. Which is that drug?
That's the memantine, that it's the NMDA antagonist, right?
Yes, that's correct. Great. So, yeah. And finally, we lead to this leads to neuronal death and then brain atrophy. Now, these are some of the things, some of the areas that are most affected. So, cortical thinning is seen, hippocampal atrophy, ventricular enlargement, and reduced brain volume. So, this is all characteristic of dementia. Cortical thinning, hippocampal atrophy, ventricular enlargement, and reduced brain volume. Now, there is progressive cognitive decline and loss of activities of daily living. So, this is the pathophysiology of dementia, which kind of helps us understand a lot of things that we are going to study further. So, I'm not going to repeat this. So, yeah. Now, moving on to the epidemiology of dementia. So, global burden: 57 million people are affected worldwide, according to 2021 census of, I think this is from WHO. I'll just confirm it, but this is, as far as I remember, it's from WHO. And then there are 10 million new cases every year, and 78, it is expected that it will increase to 78 million by 2030. Um, and this is prevalence, and this here is important. This is directly taken from CTP. So this is incidence doubles every 5 years after age of 65. So incidence of dementia doubles every 5 years. With 60 to 64, it's only 1 to 2%, and then doubles every 5 years.
Yeah.
All right, moving on. So we have some risk factors, which are divided into modifiable and non-modifiable risk factors. And I have written them separately. I'll just go into that. And yeah, this is the most common dementia worldwide is Alzheimer's dementia. Age is the greatest risk factor. Modifiable risk factors across life course can prevent or delay up to, oh, yeah. So there is Lancet Commission that I think this is 2022. I'll just like, let's just, I mean, as far as I remember, this is the paper from 2022. Lancet Commission told there are 14 modifiable risk factors. If these modifiable risk factors are addressed, the dementia risk decreases by 40%. And they divided them into three: early life, midlife, and late life. Early life involves if you address low educational attainment. Midlife, hearing loss, hypertension, obesity, traumatic brain injury, and excessive alcohol consumption. I think they have reduced them. I wrote it somewhere. Let's just look into that. Sorry, it's 2024. Yeah, I'm sorry, it's not 2022, it's
Okay.
2024. Yeah, Lancet
Yeah.
Commission findings. And this is 40% of dementia. So they said they took a life course approach, where they told that early life, this is what we did. Midlife includes 45 to 65. They said hearing loss, hypertension, obesity, excessive alcohol consumption, and traumatic brain injury. If addressed, then it will reduce 40% cases of dementia. Late life is more than 65 years of age. Physical inactivity, social isolation, air pollution, smoking, visual impairment, depression, diabetes, and untreated cardiovascular diseases. These are some of the late life risk factors. And well, these are modifiable risk factors. Then we have non modifiable risk factors. This include increasing age, family history of dementia, genetic predisposition, female sex, and Down syndrome. For example, well, with ApoE4 allele, there occurs late onset Alzheimer's. With early, well, these are some of the APP, PSEN1, PSEN2 for early onset Alzheimer's. Female sex is important here again. Female sex. This is the reason is that females live longer, and also, well, after menopause, estrogen is less, which is usually protective factor. So if there is less of estrogen, then females are more prone to developing dementia.
Yeah.
Right. Okay. Moving on. Okay, so these are the differences between. So this is most commonly, sometimes, in some way asked in the question. So how are you going to differentiate between delirium, dementia, and mild cognitive impairment? As in the delirium session, we actually discussed about delirium and dementia, but we did not discuss about mild cognitive impairment. So could you just tell me, like what you know about that, about these? So like how do you think you are going to differentiate these three?
Right. So the first thing I'm thinking about is the level of consciousness changes in delirium and the onset as well. Like delirium is more acute, whereas dementia is kind of less
Hmm.
acute, more gradual in onset.
Mm-hmm.
And what else? The disorientation changes the level of consciousness. Um, Reversibility of the conditions as well. Like delirium is a reversible condition, whereas dementia is usually not.
Mm-hmm. Except for
Um,
the reversible causes of dementia.
yeah, except for the reversible causes. Yeah.
Mm-hmm.
Delirium can present with hallucinations. Like, well, some types of dementia as well can have
Yeah.
hallucinations, like the Parkinson's
Okay.
and the Lewy body dementia. Yeah.
Mm-hmm. Okay.
Um,
What about
yeah.
mild cognitive impairment? What is the difference between dementia and mild cognitive impairment? There's just one major
Right.
difference.
I mean the level of functioning
Yeah.
impairment.
Yeah.
Yeah.
So
And also
MCI.
the score of impairment on the cognitive assessment as
Yes.
well. Yeah.
Yeah. Yeah, that's right. So delirium, you already mentioned. So this is definition, and then so progressive decline in one of. So we have already seen this. Let's just see for MCI. Objective cognitive decline greater than expected for age, but this is important. Activities of daily living remain essentially independent. There is not major decline in the activities of daily living. This is one of the major differentiating factors between dementia and MCI, because in ICD-11, if you remember, they have specifically mentioned that activity of daily living is impaired, and that is when you call them dementia, having dementia. Well, onset is, as you said, this is acute, this is more chronic, insidious. Consciousness is decreased, normal here, but maybe late dementia, consciousness might be decreased. This is normal. Attention is very much decreased, which is hallmark of delirium. And then we have mild decrease in attention in dementia and normal attention in mild cognitive impairment. Memory, well, variable, very much decreased in dementia, mild decrease in mild cognitive impairment. We have already seen about ADL, temporarily impaired, permanently impaired, preserved. Hallucinations are very common in delirium. Um, you already mentioned Lewy body dementia, where visual hallucinations are very common, rare. EEG. Now, EEG shows diffused slowing in delirium, but it's usually normal early in dementia, although when you go late in dementia, well, EEG changes. There are changes seen in EEG. Normal. Reversible, yes, usually no, sometimes. This is a medical emergency. Well, slow progression, prevent progression. So this is the difference between delirium dementia and mild cognitive impairment. Now going on to dementia versus pseudo dementia. Now, tell me, can you tell me what is the difference between them and how do you know whether it's dementia or pseudo dementia? What are few major factors that will help you decide between the two? This is also a very important
Right. Yeah.
one.
The dementia is like the memory impairment that occurs for people with depression, right? Or
Yes, you're correct. So pseudodementia is usually co-occurs in cases of depression. But let's say it's masked, we don't know. Patient just came with
yeah,
dementia symptoms. Now what?
yeah, yeah.
Um, mm-hmm. Anything?
Just trying to think like maybe the low mood in the pseudodementia, patient usually answers, I don't know, or like they wouldn't be quite concerned about the cognitive decline.
In which one? Sorry.
In the pseudodementia, right?
In
I'm
dementia.
not
Can you
quite
repeat?
sure, to be honest.
Yeah. I think you're
In
going on
the
the right track. Yeah, please repeat. Can you please repeat? I think you're right.
so in depression, the patient would not make effort to answer the question, like they would usually just say, I don't know, or not quite concerned about the cognitive decline, whereas in dementia, a patient would make effort to fill the gaps or.
Yeah. So you're partially right there. There's one thing
Okay.
from pseudodementia, from in pseudodementia that you mentioned of dementia. So you said right,
Mm.
patient would say, I don't know, not
Yeah,
not put much effort. Correct.
yeah.
But patient would be highly concerned about these deficits.
Okay, okay.
Yeah. But in this case, as you said, they would put efforts. They may say out wrong answers, but they will try to fill the gap. The
Yeah,
concern is there, but that would not quite be like the one that is seen in pseudodementia. So
right.
yeah,
Okay.
this is this is right. Anything else that you can remember? Because this will help you jog your
Uh,
memory.
yeah, other symptoms of depression, like the biological symptoms, the sleep, the appetite, the energy,
Yeah, this could be impaired even in dementia. BPSD,
that can
like
happen.
behavioral
Yeah,
psychological
yeah,
symptoms of dementia.
yeah, can happen.
Yeah.
Yeah.
Okay. Let's just see, let's just go on to this if we can find
Okay.
more things. So yeah, onset of the two. So dementia is in serious onset and gradual progression. Pseudodementia, usually seen in the context of severe depression, um, abrupt or subacute, that is what they write, and often
Yeah.
follows a depressive episode.
Yeah.
Okay, progression is slowly progressive. Now, pseudodementia can be fluctuating and it improves with treatment of depressive episode. Um, with chief complaints, family notices deficits more than the patient. Here, patient complains excessively of memory loss. So this is one important thing. Chief complaints, who is giving you the complaints? Mood, usually normal, apathetic, could be, well, I wouldn't say completely because in even in BPSD, major mood is depressive and then it is apathetic and then it is anxious. So it could be anything. So, but for the sake of it, usually normal or apathetic. And this is depressed mood, anhedonia, guilt, prominent. Then insight, poor. This is important. And here insight is preserved. Patient is more aware of their cognitive deficits. Orientation impaired, especially later. Here intact. Memory and testing. Now, we already discussed this. So there is true memory loss and
Yeah.
queuing does not help. This is important. They guess or confabulate answers to cover up memory gaps, which you mentioned. So this is correct. And then there is retrieval deficit here. They're not able to remember, but it is not like they have that storage. Storage is there, but retrieval is a problem. So queuing improves recall. If you give them cues, they will be able to remember, and often answer I don't know. So these are the signs when you ask them the questions, they will give up easily. They will show signs of distress when cannot remember, and they will show concerns regarding their performances. Um, yeah, this is the answer that they usually give. Okay, I think, sorry, I have written something about this down here. Yeah, a little bit more of it. So they try to cover up their difficulties, which we already saw. They complain about memory loss, appear distressed by their cognitive deficit. Now, this is the scale that we use for screening dementia and depression. This is Cornell scale. It has two steps, one for caregiver, which has 19 items, and one for patient interview. Um, and total time taken to you when you're using the scale is 30 minutes. So this is important. For dementia, we use Cornell scale and scales which we already discussed for true pseudo dementia and dementia. This is dementia. This is pseudo dementia. Moving on, we have activities of daily living, progressively impaired, relatively preserved, reduced mainly due to poor motivation. Then neuroimaging will have issues. So this is normal. This is not normal. Okay, even I didn't remember this. It's so easy to say that there might be cerebral atrophy, hippocampal atrophy, or vascular changes present in neuroimaging. Prognosis and treatment, progressive, usually reversible cognitive enhancers can be used, usually reversible with antidepressants plus minus psychotherapy or ECT, depending upon the situation. So yeah, this is the difference between dementia and pseudo dementia. Let's move forward with irreversible and reversible dementia. Okay, so what I'll do now is it is much better to just see the features here and then we can answer the questions. Okay, how about we discuss some of the causes of dementia, like reversible and irreversible? What are some of the reversible causes of dementia and irreversible causes of dementia? I think mostly they ask about reversible causes. So, can you name some reversible causes? One second. Yeah. So we have reversible and irreversible dementia. So some of the reversible causes of dementia is cognitive impairment due to potentially treatable condition. Well, what is the definition of these? So let's just go into the definition of these. So definition, cognitive impairment due to a potentially treatable condition and irreversible cognitive impairment due to progressive neurodegenerative disease. So potentially treatable condition, progressive neurodegenerative disease. So yeah, like when we think about this, you can think about the causes of irreversible dementia. Well, progressive neurodegenerative disease, Alzheimer's dementia, frontotemporal dementia, Lewy body dementia. These are irreversible causes of dementia, but there are some reversible causes as well. We have already discussed pseudodementia because of depression. There are other reversible causes would be if the dementia is happening because of some infection, if the dementia is happening because of other things, for example, let's say metabolic causes, um, let's say endocrine causes, for example, hypothyroidism, hypoparathyroidism. So, yeah. So, secondary to systemic, metabolic, structural, psychiatric, or infectious disorders, progressive neuronal degeneration and brain atrophy. Okay, so this is the pathology of reversible versus irreversible dementia. Moving on, we have what is the course of this? So, Reversible dementia improves. Reversible dementia may improve or completely reverse with treatment, but well, irreversible one progressively and usually is irreversible and will not just like it will just prolong the um, it will just prolong the disease, but it will not completely reverse the disease, or let's say it won't it won't sorry it won't it won't make the person come back to their usual usual form or usual memory. So the onset is often acute or subacute, here gradual or insidious. The progression is variable, may stabilize or reverse. It's slowly progressive. So the progression is slowly progressive. All right. Now the treatment, treat the underlying cause in order to treat dementia. There's symptomatic treatment, disease modifying therapies limited to selected cases. So disease modifying therapy can. So what are the disease modifying therapy? Let me know in the comment section below. What are the disease modifying therapy, examples of disease modifying therapy? Yes. So the disease modifying therapies include, well, for example, monoclonal antibodies, right? So some of them, and even like what we give for dementia also comes under disease modifying therapies. Now, moving on, prognosis. So what is the prognosis of this one? Which one? Reversible dementia. Prognosis is good if identified early. Progressive decline with loss of independence is seen in these patients. Now, what are the examples of these? So we have already discussed this: depression, hypothyroidism, vitamin B12 deficiency. What is NPH? What is the full form of NPH? Let me know in the comment section. Yes, normal pressure hydrocephalus. Normal pressure hydrocephalus. There is a triad that is seen in this. So, what is the triad that is seen in this? So, it's called as Wobby, Wacky. There's three W's: Wobby, Wacky, Wadley, something like that. So, yeah, I think there is incontinence, that is like urinary incontinence. Then there is problem with gait; they are not able to walk, so ataxia is there. And then, of course, since we are talking about dementia, is some memory loss or cognitive dysfunction. So please just correct me if I'm wrong. Okay. So these are the differences between reversible dementia and irreversible dementia. So again, reversible dementia is anything that is a secondary cause of dementia, and that can reverse potentially if you treat the condition, right? So these are for the following. We will also discuss very much in details about the reversible causes of dementia, because this is something that is important for both MD residency exams outside of UK, and also MRCpsych exam itself. So Alzheimer's disease, vascular dementia, Lewy body dementia, FTD, Parkinson's, prion, Huntington, all of these come under irreversible causes of dementia. Now, moving forward, reversible causes of dementia. So reversible causes of dementia are further divided into psychiatric causes, structural causes, and medical causes. Hello, Dr. Sai.
Hello, good evening.
Hi, good evening. How are you doing?
Yeah, I'm fine. How about you?
Yeah, I'm good. I'm good. We had like three people joined in before, and just one of them left just now. So
Yeah.
you and currently just you and me. So
Oh,
yeah, yeah. So we were discussing about reversible and irreversible causes of dementia. Could you tell could you tell some of the examples of reversible causes of dementia in terms of psychiatric, structural, and medical? So we are going to divide this into three.
psychiatric, like pseudo dementia, or any mood disorder associated with it.
Yeah, so we have, yeah, mood disorder like depression,
Hmm. Uh,
even severe anxiety in some cases can lead
yeah,
to dementia. Yeah. What about some structural causes of dementia?
well, maybe TBA in some cases it will be reversible.
Sorry,
Mild
can you please repeat that?
TBI, traumatic brain injury in some mild cases.
Yeah. Yeah. And what else?
Mm, not sure.
This NPH is also a
Normal
reversible.
pressure hydrocarbon. After relieving the pressure, yeah, it will be reversible.
Yeah. And then we have brain tumors as well, and
Brain tumor.
like metastasized or primary brain tumors.
Mm,
Then
mm.
what about medical causes? So let's divide medical causes further into too many, but can you just like tell some of the medical causes which are reversible causes of dementia?
Nutritional deficiency.
Mm-hmm.
Uh, sure, but I'm just throwing arrows in the dark. Uh, electrolyte abnormality.
Yeah. Anything else? Some infections, perhaps,
Mm.
like neurosyphilis,
Uh,
HIV.
HIV.
Sorry.
Hand. HIV associated.
Yeah.
Mm,
All right. So just let's just look into these. So we have major depressive disorder, severe anxiety, and functional
mm,
cognitive disorder as well, which
okay.
I think is a new name of pseudodementia.
Okay.
Yeah. Then we have NPH, normal pressure hydrocephalus, which we already discussed. Chronic
Mm,
subdural hematoma is something that we missed, and visual or hearing impairment. So if you correct
okay.
these, then
Okay.
we can, yeah, have reversible ability in dementia.
Mm,
Okay, medical causes include where, oh yeah, we completely forgot these drugs and
mm.
alcohol.
That's yeah.
Yeah, so I have divided them into drugs and alcohol, metabolic,
Mm,
endocrine, and autoimmune, and then infections. So,
mm,
drugs and alcohol, use of anticholinergics definitely will lead
mm,
to dementia.
mm,
Benzodiazepines, alcohol, opioids, and corticosteroids.
mm.
Then we have metabolic, endocrine, autoimmune. You already mentioned, I think you mentioned vitamin B12 deficiency,
Yeah.
folate
Mm,
deficiency, and then this is nutritional causes.
yeah.
Hypothyroidism, hypoparathyroidism
Endocrine,
are,
right?
yeah. And we have autoimmune causes, that is Wilson's disease, Addison's disease, Hashimoto, and encephalitis.
Mm,
So Wilson's is copper deposition, but again,
mm,
it
mm,
converts into um, autoantibodies attacking our system.
mm,
Um, okay, then we have infections, and this too, HIV-associated neurocognitive dementia,
mm.
neurosyphilis. Additionally, we have also Whipple's disease, sarcoidosis, and meningitis. Whipple's
Okay.
disease, sarcoidosis, and meningitis. So these
Mm,
are some of the reversible causes of dementia.
mm, mm.
Um, so, and therefore, a basic workup should include all of these. Since we have already seen the reversible causes, whenever we are going to write the answer in the exam, we can include CBC, vitamin B12 and folate, thyroid function test, electrolytes. You mentioned electrolytes, calcium, renal and liver dysfunction, HIV, syphilis serology, when indicated, brain imaging to detect NPH, tumors, or chronic subdural hematoma, with the reasoning.
Mm.
Wonderful. Now, I we already discussed dementia versus pseudodementia. I don't know why this table is okay. I think I wrote it twice. Okay. Okay, so primary and secondary neurodegenerative disorders. Could you tell some of the examples of primary and some of the examples of secondary neurodegenerative disorder? So what I have done here is first I have differentiated all types of dementia. So first we went to delirium dementia and mild cognitive impairment. Then we went on to see dementia and pseudodementia. Then we went on to see reversible and irreversible dementia. And now we
Okay.
are looking at primary and secondary neurodegenerative disorders. So, what
Okay.
are the, yeah. So, because I have seen like they can ask questions in regarding, anything like you tell us like what is primary and what is secondary neurodegenerative disorders. So could you tell me examples of the three of these?
By the name, I am assuming primary means is directly related to the cerebral parenchyma, and
Mm-hmm.
secondary, as the name suggests, it's secondary to some other cause.
Yeah.
Or it
So
might be the associated feature of some other systemic disease.
yeah, you're right. So could you name some of the primary and some of the secondary neurodegenerative
Primary
disorders?
like uh, Alzheimer's, frontotemporal Lewy body dementia.
Hmm. Yeah, you're correct. Secondary?
Secondary might be, as you were previously mentioned, secondary to some metastatic disease. I'm assuming, but I'm not sure because I haven't yet
Yeah. Yeah, I think Huntington's will also come under secondary neurodegenerative dementia, but that's just, sorry, it's primary. Yeah. So Alzheimer's, Lewy body, Parkinson's disease, frontotemporal, Huntington's, and prions. And
read.
secondary is due to
Okay.
vascular
Rest
causes.
everything is secondary. Okay.
Yeah. All right.
Okay. Mm.
Okay. Now, cortical and subcortical dementia. Right. Okay. So this is a very good topic,
Mm.
both for MRCpsych and our exams.
Okay.
So, yeah. So, can you like tell me what is the difference between just jogging our memory? What is the difference
Mm.
between cortical and subcortical dementia?
Subcortical maybe the structures like the hippocampus and medial temporal structures involved in memory formation might be impaired. And cortical dementia is directly related to maybe the prefrontal cortex.
Sorry, can
Might
you repeat the
metastasis.
subcortical? No, what did you say about
Subcortical
sub?
is it's related to subcortical structures like hippocampus and medial temporal structures involved in the memory formation.
Okay.
Mm.
Isn't medial temporal a cortical structure?
No, I'm telling
Temporal
about
lobe.
the subcortical dementia.
Yeah, but medial temporal lobe structures wouldn't they come under cortical dementia?
I'm not sure. I'm not sure.
Yeah, I think yeah, like everything related to cortex. So subcortical would be everything um, after thalamus.
Okay.
So and before it is everything is cortical.
Okay.
Yeah. So these are yeah. So the primary pathology, cortical dementia, is degeneration of cerebral cortex.
Okay. Okay.
And
Okay.
these will include hippocampus, temporal, parietal, frontal association cortex, all of these. So
Mm.
everything above thalamus, everything and everything that is like that goes down, like basal ganglia,
Mm.
brainstem, all of these. Basal ganglia, thalamocortical circuits, white matter, like doesn't matter, brainstem, and frontal subcortical pathways also
Okay.
are involved in subcortical dementia, like are
Okay.
actually a part of subcortex structures of brain.
Okay.
Okay, so next is like all in all, if we see, we have cortical structures are these, and if these are involved, then this is called as cortical dementia. If
Yeah.
these are involved, then this is called as subcortical dementia. Could you
Okay.
name some of the pathologies of cortical dementia and subcortical dementia? Let's just think about them.
I'm not sure. According to primary causes, I think I've read somewhere Levy body will come under subcortical, but I'm not sure. I'm not able to recollect.
No, no, it's okay. You can just guess. It's fine.
Two of the main primary causes come under cortical, and two of them come under subcortical, but I don't exactly remember. I think Alzheimer's, the deposits will be everywhere.
Will be Alzheimer's would be cortical or subcortical.
I'm not sure.
Yeah. So yeah, there are like primary pathology, Alzheimer's dementia would be cortical. So if we come here, Alzheimer's is cortical, Lewy body is cortical, even frontotemporal because it's involving frontal and temporal lobes is cortical.
Okay.
And then if we go down, Huntington's involves basal ganglia. So it would be subcortical. And
Parkinson.
Sons would involve basal ganglia. So it would be subcortical. But as you said, there's one primary pathology called as vascular dementia. Now, vascular dementia can either be cortical or subcortical, depending upon where the block is. So it will depend upon the infarct or ischemic area. So if it is cortical, then it will be cortex. Subcortical. Subcortical has a name which is as Biswenger, something like that. Let's just look into that.
It's like a some small
Binswenger.
vessel ischemic disease, I think. Small vessel white matter ischemic disease. It also have
Yeah.
some other.
Yeah, you're right. You're right. Binswenger, which is small vessel ischemic white matter disease, vascular dementia. It actually is subcortical arteriosclerotic plaques are formed. It's also known as subcortical arteriosclerotic encephalopathy. So we are right. Alzheimer's dementia, frontotemporal dementia, we have Prions disease, primary progressive aphasia. All of these come under cortical dementia. Then we have subcortical ones, which we have already discussed. Progressive supranuclear palsy is also a part of subcortical. Wilson's disease, HIV dementia, and this one.
Okay. Okay.
Now, what is the main cognitive deficit? Now, this is very important because there are a lot of differences that come under cortical dementia and subcortical. So this is important for clinics, actually.
Okay.
So with while doing some tests and some memory function test and cognitive test, we would be able to identify whether the lesion is subcortical or cortical. So let's say, and also with the history. So main cognitive deficit in case of cortical dementia is loss of higher cortical functions.
Okay.
So higher cortical functions would involve everything related with think about.
Executive functioning, movements, speech.
I'm sorry, your voice is a little. I'm not able to understand. I think it's breaking. Could you repeat that?
Yeah, the cortical functions include everything you mentioned. I'm just telling like executive function, reasoning, abstraction.
Yeah, all of those functions. So executive functions, um, language,
Yeah.
and well, other functions as well,
Mm.
memory and
Mm.
stuff. So now the thing here, there is slowing of information processing. So information is there, but the processing is slowed. And this is called as bradiphrenia. That means slowing of thoughts. So
Mm.
slowing of information processing or slowing of thoughts is bradiphrenia. And now this is a very important part here. Memory. Like there is a very different kind of memory deficit that is seen in both of them. Very, very different. So here, problem is in encoding and storage. I'm sorry.
Mm.
And here, the problem is in retrieval.
Okay.
So memory generally goes like this. So we learn something, then it is encoded, and then it is stored hippocampus, and then it is retrieved when it is required,
Mm.
right? So in case of cortical dementia, the problem is here in encoding and storage.
Okay.
So whatever we learn is not encoded, is not stored.
Mm.
So there is there is no question of retrieval.
Mm.
But if it is a subcortical dementia, when there is a new information coming in, you will learn, you will encode it, and you will store it because cortical part is intact. Because
Yeah.
encoding and storage is done in the cortex. Hippocampus is involved in that. But retrieval is done using the fronto-subcortical connections.
Okay.
So we have fronto-subcortical connections. So we have basal ganglia, we have thalamus, and then there is so this is like there's a loop is formed. So we have the information coming in. Basal ganglia is involved, thalamus is involved. Thalamus sends the signals to cortex. Then cortex tells, okay, this is it, and then it comes back. So this system here, the fronto-subcortical connection is dysfunctional, and therefore the problem is in retrieval. So we are not able to retrieve that information, but
Mm.
it actually improves with queuing. So if you give a cue to the patient, they will be able to retrieve it. You just have to tell, okay, there's a cue here. So that will help with the retrieval. So this is one major difference between the cortical and subcortical dementia.
Mm.
Now, because higher cognitive functions are impaired, definitely attention. Okay, I'm sorry, but this is the opposite of that. Attention is not impaired in cortical, usually preserved early. And here it is impaired early because of slowed cognition. Okay, this is the reason why. The slowed cognition, that is bradykrinia, and that is because of fronto-subcortical pathways impairment. So, yeah. Then moving forward, now this is also important. There is a difference between the language that is gone. So here, aphasia is common. We have already discussed this. So aphasia could be Broca's, Wernicke's, conduction, or global, depending upon the location of the problem. So if it is in the temporal lobe of where Broca's area is located, where if Wernicke's and conduction, there's arcuate fasciculus is located, or global completely. So aphasia will depend upon the location. And it could be even fluent or non-fluent depending upon these things. But in the early stages here in the subcortical, language is preserved. Speech may be dysarthric or hypophonic, but there is no aphasia.
Okay.
Okay. Moving on, praxis. Okay, can you tell me what is apraxia? What actually is apraxia?
That one is not able to perform a learned act with intact sensory and motor pathways.
Wonderful, wonderful. Yeah, correct. So, apraxia is, well, difficulty performing learned motor acts. So, which would be definitely common in cortical, but it is preserved in subcortical part. So, apraxia is that. Now, what is agnosia?
Not able to recognize
Yes, correct. So, agnosia is inability to recognize or identify familiar objects,
familiar
people,
objects.
places. And there is one more important thing here, which is this: despite normal vision and normal level of consciousness and adequate language ability. So everything is normal, but they are not able to recognize it. Now, agnosia definitely, because it is a part of, it is something that is dealt in the frontal, in the cortex. So this will be, agnosia would be common in the cortical part, but absent in subcortical. Visuospatial skills here would be markedly impaired. For example, patient would get lost and constructional apraxia would also be seen. What do you mean by constructional apraxia?
They ask a person to draw, like we do in MMSC, we'll do some two intersecting pentagons, we'll ask them to draw. No?
Yeah, so that is
Not
impaired.
able
Correct.
to,
Copy the object.
yeah.
Yeah. Well, copying was also seen with agnosia. I sometimes have like um, um, problem in understanding some parts of agnosia where we also ask patient to draw. There's some kind of agnosia also where we ask the patient to draw and copy.
Okay.
Yeah, but we'll just go into that later.
Okay.
Yeah, so you're right. Next up, we have visuospatial skills. They will get lost. Constructional apraxia will be seen, but here it is usually preserved initially, but mild impairment later can be seen. Now, executive functions. Ooh, they say this is affected later, except FTD, where it is early. I am very not satisfied with this. And they say this is affected early here due to frontal subcortical circuit dysfunction. Whoa.
I think there is some overlap in between these things,
Yeah. 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 I think so too.
especially in this domain.
Yeah. You're right. So would it be correct to write it this way then or not?
Not exactly sure. I think if we are unsure of something, we better avoid it instead of telling something and getting in stuck with the examiner.
Yeah. Yeah. Okay. Yeah. In that case, we would just try to avoid this one. And then processing speed, yes, markedly slowed because of frontocortical disconnection and normal until late. Motor symptoms, EPS, absent or would come later.
Mhm.
Early and prominent because of involvement of, well,
The
basal
basic
ganglia.
structures. Mm.
Yeah. So all of these symptoms of Parkinsonism would be present here. And then we have gait, normal until advanced diseases. There's early shuffling gait, freezing and falls because everything is controlled by subcortical structures here. Abnormal movements are rare. Here, they are common. In Huntington's chorea, Huntington's disease, we can see chorea. Parkinson's, we can see dementia. Sorry, tremors and dystonia or myoclonus, depending on the cause of the disease.
Mm.
Then we have mood or personality changes. Personality is usually preserved, except for FTD. Behavioral changes can occur, but they are later. Here, personality changes occur early. So we have apathy, depression, reduced motivation, which can be seen early. Insight, often poor as disease progresses, better preserved initially, but then, of course, insight becomes poor. Imaging, in imaging, we would see cortical atrophy and hippocampal atrophy. Here in imaging, we would see basal ganglia changes, white matter lesions, ventricular enlargement, depending upon the cause.
Okay.
So, yeah, this is the difference between cortical and subcortical dementia. Then, moving forward, why do these differences occur? I think we already discussed on this one, but yeah,
Yeah.
we can see a little bit about aphasia. Language cortex, dominant temporal and frontal lobes are damaged. So language we already see temporal and frontal lobes. Then apraxia happens because of parietal lobe damage. Parietal association cortex is damaged. Agnosia happens because of association cortex cannot interpret sensory information. However, sensory association cortex is intact here. Yeah, this we discussed already.
Mm.
This we discussed already. Okay. So how you can remember cortical dementia and subcortical dementia is 4 A's and 4 B's. So A for aphasia, apraxia, agnosia, Alzheimer's. 4 B's,
Okay.
bradyphrenia, bradykinesia, basal ganglia pathology, better recognition than
Got it.
recall. This is important.
Okay.
Better recognition than recall. Okay. Um, Yeah, so we have these are some of the important important things that we will need to study in dementia. Under cortical dementias, Alzheimer's, Lewy body, vascular, and frontotemporal. Under
Mm.
subcortical, we have Parkinson's disease, Huntington's, NPH, BPS. Well, BPSD is not under that, but it will just come in all of them, and we will also look at these.
Yes,
Uh,
includes. Okay.
Yeah. So this is the summary table that I asked ChatGPT to create using my notes. It's a
Okay.
nice one. Yeah, I think we discussed all of them. So yeah, mixed dementia is something and rapidly progressive dementia. Do you know anything about these?
Mm. Rapidly progressive, I'm aware in variant CJD, I think. In one type of Creutzfeldt-Jacobson disease, rapidly progressive
Okay.
dementia.
Okay.
Not
Okay.
within a couple of years, it will rapidly progress. If I'm not
Which
wrong.
one?
The Creutzfeldt-Jacobson disease. One
Okay.
variant of it. I'm not sure,
Okay.
but it
Yeah,
might be
okay, okay.
different.
We'll see into it. Even I have not read CJD yet. But yeah, I think you're right, probably. I think I might have also read that. Then mixed dementia, it says, is usually Alzheimer's and vascular dementia, for example, are most common mixed dementias. Features of both
Okay.
cortical and subcortical involvement is known as
Okay.
mixed dementia.
Mm.
Yeah, it's a very, very nice table actually. So this is prominent memory, language, visuospatial deficits, aphasia, apraxia, agnosia, motor signs come late. In
Mm.
subcortical, slowing of thoughts and activities, executive dysfunction is early. Parkinsonism, gait disturbances, language and visuospatial deficits, minimal. Very
Mm.
nice. All right. Yeah, let's move forward to we discussed the risk factors early on.
Okay.
So we
Okay.
will move forward to the etiologies of dementia, which we have already discussed. So I don't think we need to discuss it again. So we'll
No, no.
just look
Mm.
into the headings of these. So under
Okay.
neurodegenerative, we know like all the primary kinds of dementia will come, like primary what was it called? Primary, I forgot the name,
Degenerative.
secondary, and yeah, primary neurodegenerative dementias would
Mm.
come under neurodegenerative causes of dementia. And then we have vascular causes, which we already saw infarction, Binswanger disease.
Mm.
Then there's hemodynamic insufficiency as well, which would come under this. Then we
Mm.
have neurological causes, multiple sclerosis. Fourth is endocrine causes, we have seen. Fifth is nutritional, we have seen. Sixth is infectious. We have seen cryptococcus is something they have added. Seventh is metabolic that we have already seen. Metachromatic leukodystrophy is another one. Traumatic, subdural hematoma and chronic traumatic encephalopathy. Okay, yeah. So this was a question I was asked. Dementia pugilistica. Do you remember? Do you know what this is? I
Yeah,
was
that's
asked this.
also,
Yeah,
yeah, punch drunk syndrome
yeah. Like what
in
happens in
boxers
this?
who were uh, in boxers who are there'll be subcortical, in fact, there'll be initially subcortical bleeds
Okay. In
uh,
which one are you talking about?
on the punch drunk syndrome, dementia
Okay.
paglistica.
Okay. Okay. Okay.
Because of repeated assault to the head, they'll be having some subcortical hemorrhages.
Bleed. Okay.
It will lead to some changes like even aggression and memory loss.
Yeah.
Yeah, only that thing I'm able to remember.
No, no. You're right. You're right. And okay, why is it called as punch drunk syndrome? Like, is it because the patient gets punched or patient punches someone?
Patient gets punched, I think. Yeah,
Patient patient punches
gets punched.
someone, assaults someone, and then they forget, right?
Oh, I'm not sure. It is first time I'm hearing because I was assuming till later because he used to get punched, no? Oh, this
Okay,
is one very new thing.
then why would
Okay.
it come under dementia? I mean, it won't matter if he's punched and drunk then. Okay, we'll just look into this. Even I'm not
Okay.
sure, but yeah, thank you for jogging that memory up.
Mm.
Okay, exposure. I've already seen this. Okay, so these are the clinical features of dementia, which I've divided into three parts. That this
Okay.
is from CTP.
Okay.
So impairment in cognitive domain, impairment in functional domain, and neuropsychiatric manifestations. Were you the one who sent me the? I think you only sent me the PPTs, right?
Yeah. Yeah.
PowerPoint.
Yeah.
Yeah, they were really nice. I actually like went through them. I used some
Okay.
of the things from there also. So
Okay. Okay. But I didn't go through the PDFs. The PPTs, I don't know. They are just in my phone, but I didn't see. I just skimmed through them. I thought it would be helpful and I sent them.
thank you so much. So
Mm.
she
Welcome.
created, I think it was created by someone called as Gayatri, Dr. Gayatri. I
Mm.
maybe I'm wrong, but her name started with G.
Okay.
So she created everything from CTP because I was going through CTP and I saw like
Yeah,
she's taken.
Alzheimer's. Yeah. Yeah.
Yeah,
Mm.
it's nice. So this is how they divided clinical features of dementia. So when we talk about impairment in cognitive functions, impairment in cognitive domains, according to DSM-5, well, according to we'll just go into ICD-11 because I have some confusion with DSM-5. According to
Okay.
ICD-11, it should be present in at least two cognitive domains. Impairment should at least be present in two cognitive domains.
Okay.
Yeah. Um, then cognitive impairment would include learning and memory impairment. So when there is
Mm.
learning and memory impairment, patient would be unable to um, sorry, patient would be unable to learn new information or to recall previously learned information. So we have already seen this. Learn new
Oh.
information, cortical dementia. Previously
Mm.
recalled, subcortical dementia. So
Mm.
short-term memory is goes first, then the long-term memory, early
Mm.
stages.
Okay.
Then moving on to we have language impairment. Under language impairment, we have aphasia, which is seen in cortical dementia, which we have already discussed. And
Okay.
if we want to write it and understand it, so patient would have word finding difficulties, fluency would be decreased, mispronunciation of the words will happen, patient would try to substitute the words, and
Okay.
anomia for objects and people would be present. So when we were talking about the agnosia, so yeah, this is where I was a little confused. So anomia for object is present in this as aphasia as well, and agnosia also means so agnosia is not a part of language problem, right?
Okay.
Aphasia is a part of
Agnosia,
language.
yeah, aphasia is mainly concerned with the language. Agnosia, it has different things like finger agnosia, agnosia to faces.
For prosopagnosia.
Yeah, prosopagnosia, and it also has different things.
Okay. Okay. Here they are not.
There
This
is
is
one
very
thing like
different.
somatognosia is also there, no?
Which one?
Not able to recognize somatognosia, hemisomatognosia, if I'm right. Uh,
Yeah. There's one more
Palatal.
which semi. What happens in semi
Hemat-
somatognosia?
yeah, in hemisomatognosia, I think the half parts of the body will get neglected.
Hemi. Okay. Okay.
Yeah,
There's one
hemi.
auto. Yeah. 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 And there's some auto something where patient does not
Not
recognize their
able to
own
recognize
body
their own
part.
space. Yeah.
Yeah. Yeah. Okay. Great. Great. Then next is perceptual motor impairment. So under perceptual and motor impairment, we have visual perception, visual construction, apraxia, and agnosia. So visual perception, if there is then difficulty in interpreting visual stimuli. In visual construction, patient will have difficulty in drawing. So this is what I was saying. So I was little confused between apraxia and
Okay.
visual construction as well. So
Okay.
this is also very overlapping. So in visual construction, difficulty in drawing or constructing or copying shapes. Similarly,
Mhm.
in constructional apraxia, you said problems are there in. Oh, so is it the same
I
thing then?
think it is the same. Yeah.
Yeah. Okay. Okay. Got it. Got it. So apraxia, we already saw difficulty performing learned motor acts, and agnosia, problem with recognition. So we have seen three here: learning and memory, language impairment, perceptual motor impairment,
Motor impairment,
impairment in
executive function.
executive functioning.
Okay.
So this is what you were saying: planning, organizing, sequencing, and abstracting.
Abstract.
So all of these complex tasks are impaired.
Mm.
Example of these tasks include preparing a meal, managing medications on their own, or managing their own finances.
Okay.
So all of this is impaired. Then we have impairment in complex attention. For example, if a patient is watching a movie and then there is like a postman coming in on the door, there are children shouting as well. So with all of this, patient would not have like they will not be able to pour their attention on one task, and they will be little what do you say uh
Focused
they'll go
on only a single task at time.
sorry, what?
They'll be able to focus only on one task at a time.
Yeah,
If that's
and
what you wanted to say. Yeah.
yeah, and I mean, yeah, they won't be able to do everything on everything, so complex attention would not be there. You're right. Okay, impairment in social cognition, ability to recognize emotions and ability to consider another individual's mental state.
Yeah.
Yeah. Okay. So under functional impairment, so these are the six things in under cognitive impairment. Can you repeat
Okay.
them? What are the six things?
Language, motor. Mm,
Language, motor.
now we have discussed the apraxia, agnosia. So,
Yeah. So that will come under impairment in visual perception, I think.
mm,
And then we have perception motor. Then we have language and
mm,
memory, learning and memory,
and
language.
the
We
executive
also,
function like
yeah,
abstraction and
executive.
everything.
Yeah,
Mm.
executive functions. What else? The last one that we
Complex
just said,
attention.
complex attention
Complex attention.
and social cognition.
Social cognition.
Yeah, perceptual motor, language impairment, and okay. Got it. Then next is functional impairment. So significant impairment is present and reduced from previous level of functioning. So initially, CTP says that patient would have problems in instrumental activities of daily living. Later, they will progress, to basic activities of daily living. So what are the
Okay.
instrumental activities of daily living? Over here, transportation, using the
Ah, yeah.
telephone.
Using
Yeah.
telephone, meal preparation, medication. Okay.
Yeah. And then very, very basic things, moving on their own, dressing, grooming, bathing, feeding,
Mm.
toileting. So
Like
this is
under the
one.
basics. Okay.
Yeah. Okay. Moving on, we have what are the neuropsychiatric manifestations that are seen in these patients? Any,
We can
can you name
we
a
can
few?
rate everything. We can rate
Yeah, we can
everything.
actually write
Starting
everything.
from
Like,
F10 to
can you just name a few then?
yeah, most common associated depression, uh,
Okay. Yeah, you're right.
psychosis,
Sorry.
psychosis,
Yeah.
organic psychosis,
Yeah.
uh, mania.
Yeah.
I
Yeah.
have to
Actually,
start. This is one. This is one trick which I'm planning to use in our final exams too.
yeah.
Whenever
Actually.
any neuropsychiatric aspect comes, there'll be some
Mm-hmm.
specific things. No, like depression is seen in post-stroke. Post-stroke depression is there. After following MI, depression is common, and we can write rest everything. That's what I'm planning to do.
Okay. So can we do that?
Yeah, definitely. With a short span of time, what we're having right now, I'm just planning to remember what are all the main things.
Okay. All right. So are you preparing some notes as well for these?
No, no. As of now, I'm not preparing. I'm using Psych Reads notes as of now.
Oh, awesome. So I have taken their class?
There is one course called Code Red. You might be aware of it. No?
Yeah, 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 I am.
Code Red. Yeah. As of now, I'm keeping it as my source of preparation
Oh, wonderful. I'm
because
using
previous I haven't made notes. Yeah, tell me.
yeah. So can I like if I have any doubts, can I like ask you because there are some things I don't understand from
Yeah,
code red sometimes.
definitely.
Okay,
Definitely,
wonderful.
definitely. I will try to help.
Wonderful. Yeah, thank
Mm.
you.
Yeah,
All right.
welcome. And I would also like to do the same thing.
Of course, of course.
Uh, One
Great.
main thing while preparing
Hmm.
for the exams, which I felt was this information overload. Like what do we do? PPTs, we are having standard books like CTP, task months. For substance, we are having 2 to 3 books. For
Yeah.
guidelines, we are having Maudsley, IPS CPG guidelines.
A lot of
So
them.
I've thought one thing that now this is my personal thing. Now I'm not able to prepare. I previously was reading standard textbooks only because we'll be having this FOMO now. We have to read from standard textbooks. But now
Right.
when I try to revise it, it's like very new language altogether to me.
Oh my
I
God.
felt
Even after you read the standard textbooks.
particular topics I have read the standard textbooks, but
Mm-hmm.
there is so much and so much of information we can't put it in one place.
Yeah, and the thing is, see, I'm trying to understand how to write the answer. I mean, the
Exactly.
thing is, so I just don't understand. Oh my God. I was trying to prepare BPSD today,
Mm,
and then I'm
mm,
like, I don't get it, man. I just don't understand how to write it. Even
yeah,
for FTDs, I'm not able to understand how to write the answer because the questions are very, very weird questions. I'll
yeah.
share questions with you. So
Okay.
they ask about dementia first, define dementia, and then they
Mm,
ask one more question regarding dementia. They ask one
mm,
question with in the same question. They ask one question of Alzheimer's disease,
mm.
and then they ask management of dementia. So I don't understand in management of dementia. Should I write? What should I write? Should I write because there are too many types of dementia? So do I have to
Yeah,
write the management of all those
you
dementias?
know, exactly. That's the reason why I took this code rate.
No, even
I
I
thought
have
of
it.
taking. Yeah, yeah, yeah. I think that would be better because we are having. I don't know when are you having the exam. I'm having in September month, September end.
Yeah, same, same. My exams are from 28th of September.
You
And
are from
I
which
have,
state?
I'm from Madhya Pradesh.
Okay, okay. I'm from Andhra. We are
Mm-hmm.
having from September 22nd till September 28th. We are having.
Okay, we have 28th to 3rd October.
Okay, okay. So that's why
Yeah.
I took the code red and now I'm just using those notes.
Okay, so did you like watch the videos as well?
Currently, I have finished the 2 papers. Those are like very short duration only. Within 4 to 5 days, we can finish off watching papers, one
Okay,
paper.
wonderful. Wonderful.
Yeah, now I'm
You
currently
seem,
doing my paper 3. Hmm.
yeah, you seem to have like a good, what do you call it? Like good hand. like you say, good catch over some of the concepts here. For
No, no,
example,
that's totally because I prepared for paper A last year.
last year. Oh,
Yeah,
okay. You gave your
I finished I finished my RC Psych paper A last year itself.
That is
The
awesome.
only
I should
time
have
when
done.
that
I
was
should
the
have done
only
this.
time when I've read sincerely for the 2 or 2.5 months.
Wow, amazing, man,
Now I'm coming to
amazing.
realize that was so helpful.
God damn it. So nice. So nice. I feel I should have also given that. I didn't have enough time though. So yeah, I'm
Yeah.
doing it. I have done like I'm also using the code red. I have
Okay.
done most of it, but again, as I
Mm.
said, they have not covered everything. Of course, they can't in code red. Everything cannot be covered.
Obviously. Yeah.
But for example, this question, I was not able to understand what to write in management of dementia. So should we write every dementia and then their management? I don't know how to cover this. I was like, it took me so much time to completely organize everything. so,
Yeah, in
so
coded, a lot of things are missing, but what we need for exams, that is there. We have an overview idea, no?
yeah.
We have an idea, like these are the primary causes, these are the secondary causes. How do you treat primary causes? They are obviously neurodegenerative things. So now, are there any specific drugs targeting to improve the cognition? We have to write about those drugs.
So it's like we can just give you they don't want a
Yeah,
specific answer. We can just give them an overview of what we know. So we know about
yeah,
acetylcholinesterase inhibitors, reversible,
exactly,
irreversible, side
exactly,
effects of them,
exactly.
the
Because
dose
we
of them.
know these are primary or not treatable, no? So we'll give symptomatic treatment. In secondary causes, based on cause, for one cause, we can write no. For NPS, we leave this thing. For nutritional deficiencies, treat the deficiency.
So
For
we can just
tumors,
like
you may have to exercise. Yeah.
hmm.
And
Okay.
also another thing, what I am planning to do in these
Mm-hmm.
couple of months is, uh, we are having the conceptual psychiatry. They have released the notes, no, in question and answer
Acha.
format.
Okay, I don't know that.
Conceptual psychiatry people, not in like textbook format. They have released in like question and answer format for every paper. There are 4 volumes of books.
Okay,
If you are
but
able
that
to
would
get,
be too much.
that'll be too much. Yeah, obviously.
Honestly,
For
I would
psychology,
not.
yeah,
Yeah, I would not want my visual memory to be distributed now. If I'm using one
exactly.
thing, then I would just go with that
You
because
stick on to one
when
thing.
yeah,
Exactly.
when you revise it, you remember the visual memory of that.
Mm.
So yeah, I would not. I would also not like. I would say like don't go with it. I mean, yes, definitely you can
Mm,
use
mm.
it for reference,
As a
and
supplement,
then
yeah, as a supplement. Today,
yeah,
I've also felt the same because in a span of 4 to 5 hours, they have covered entire child psychiatry. They have covered entire forensic. That would not be possible, no. But
yeah.
now I'm thinking in such a way that okay, if this question comes, I have to be able to fill in at least little bit of matter.
Right,
And I am
right. We
also
should have
thinking
at
at least
least
something is better than nothing.
some idea of the thing. I
Yeah,
agree.
yeah,
Completely agree. All right. All right.
exactly.
We can talk about it in detail after this. This class
Okay,
is getting yeah is getting recorded. So I
okay,
would
okay.
really yeah let's just discuss about it because and even we can also discuss on the timetable. Like we can also have like accountability for each other. And if there are
Okay.
some things we can read at the same time, and
Hmm.
then discuss about them if that's
Okay.
feasible for you too
Okay.
later.
Okay. Hmm.
Okay. Okay, so we have, as you said, major depression in mood changes. We have so neuropsychiatric manifestation would include mood changes, anxiety, personality changes, psychosis, sleep disturbances, agitation and aggression, and other behavioral disturbances.
Okay.
So now, there was a doubt that came. That is when I was reading about BPSD.
Okay.
BPSD had the same things, more or less, just one or two extra things. That's it, but more or
Okay.
less they were same thing. So is PPSD like when we talk about neuropsychiatric manifestations of dementia, this
Hmm.
is actually that we are talking about BPSD, isn't it? Like I'm asking
Exactly.
you.
No, no.
Okay.
Neuropsychiatric aspects include everything, like the psychiatric parts associated with the neurological illness, what we are calling as dementia.
So
Like the
isn't that the
psychopathologists, we
same
have
as
to write.
yeah? Isn't that the same as BPSD?
BPSD is also one of the things.
Okay, but when we actually read about BPSD, all of these things are given there. Mood changes, like everything. So they divide it into behavioral aspects and psychological aspects, and all of these aspects are actually discussed in neuropsychiatric manifestations itself. So what do
Okay,
you think?
okay. Uh, from what I know, BPSD includes these behavioral changes, these personality changes, everything will be
Yeah,
there, but
yeah.
not to such an extent that it can be categorized as an independent psychiatric illness.
Okay. So what is the difference between neuropsychiatric manifestations and BPSD? One difference.
BPSD is also one of the neuropsychiatric manifestations.
Okay. Okay.
Okay.
Okay. Got it. Got it.
If possible, I'll try to send any PPT. I think I have one PPT based on solely based on BPSD.
Sure, sure. Thank you. Yeah, would be wonderful. Okay, so we have major depression, early
Okay, let
course.
me give you an example.
Yeah.
When it comes to BPSD, the behavioral
Mm-hmm.
changes, which might be like increased sexual behavior, over jocularity, or getting
Mm-hmm.
aggression.
Mm-hmm.
Uh, this is important. This is actually a recent entity. This is important because this is overlooked in patients who are older people.
Okay.
And some studies say even before the onset of clear-cut dementia features,
Mm-hmm.
they will be associated with the behavioral changes. But let me read
Okay.
it clearly and once tell it to you. Okay.
Behavioral changes even before the onset of dementia changes. Oh, okay. Very. I thought BPSD usually comes late after. I mean, it is an integral part of dementia, but
Mm.
it neuropsychiatric manifestations except for frontotemporal dementia usually occur neuropsychiatric manifestations of BPSD usually occur late in dementia, isn't
Okay.
it?
I'm not sure, but okay. If I give you misinformation, I'll get clarity and then I'll explain it to you. Or if there is any PPT, then I'll definitely send you.
All right, thank you. Wonderful. That would be great.
Okay. Okay.
Okay, so we have major depressive symptoms here. We have major depression, which comes in early in the course. So, as you said, like this is okay, this could be a difference. BPSD is usually
Mm.
later. It is like late onset of it comes in late phases of dementia, but mood changes comes like major depression comes in early phase.
Okay.
So this is one of the
Okay.
neuropsychiatric manifestation. So basically, we can say that neuropsychiatric manifestations can be independently present, does not lead to BPSD. BPSD may be multiple neuropsychiatric manifestations present together.
Okay.
I think so. I'm not sure, but this could be
Yeah, I'm
so.
also not sure. I have to
Yeah.
once go through one textbook. Mm.
Okay. So we have depressive symptoms. Why location that is affected usually in these patients with depressive symptoms, having neurocognitive disorders like dementia, is
Okay.
hypometabolism of temporal lobe and anterior cingulate gyrus. So they have temporal lobe and anterior cingulate gyrus may hypometabolism is present. Then other mood changes are emotional lability and irritability is also present in these patients. Then moving on to anxiety, which is present in major chunk of the patients. Manifestations is patient has fear to be alone, and some patients even show catastrophic reactions. Now, can you tell me what is catastrophic reaction? Because there can be a short note that can come for catastrophic reaction.
Yeah, catastrophic reaction means even for a very little thing, they might cry a lot, or even for a very little situation what they don't like, they might react in an overly aggressive manner.
Yeah. So why does this occur?
Uh, Again, I'm just guessing that is maybe because of the decreased cortical inhibition.
Okay. Okay.
I'm
Um,
assuming, but I'm not sure.
yeah. Okay. I read about it was that it usually occurs because patient wants to do that thing, like
Okay,
they want to perform it, but because it's not because of disinhibition. I don't think so, but
okay,
it is more
okay,
because of and they being unable to do that, and then there is a frustration that occurs, and then
okay,
sudden breakdown that occurs, which actually
okay.
is shown as a catastrophic reaction,
Catastrophic
and
reaction.
catastrophic
Okay,
reaction is usually precipitated. It is not, it will
Okay.
occur out of blue. So if you give
Okay.
them tasks that are complex,
Okay.
complex tasks, it's not a simple task. For example, there are 3 or 4 instructions together in the task.
Okay.
Then, and they are unable to do it, then they will get
Okay.
frustrated and land into catastrophic reaction.
Okay. Okay.
So the treatment or the way you can do it is we tell the caregivers that do not, I mean, don't give them complex tasks. Whenever you are giving them tasks, give them very simple
We have
tasks
to.
and
Mm.
appreciate them for completing them.
Okay. Okay.
And then there was one more thing. There are like 3, 4 things. They're very non-pharmacological thing is there. Treatment is there.
Okay. Okay.
Yeah. Simple tasks and appreciate them. And then if you feel that this could occur, you can also
Mm.
prevent it.
Okay.
Yeah, prevent it by calming them down somehow. There are
Okay.
like strategies that you can use for that. And
Mm.
yeah, making them aware that it is okay to
Mm.
not be able to do, and then support.
Okay.
Caregiver support is important here rather
Mm.
than high expressed emotions. No.
Okay.
Yeah. Okay. Yeah, but you were right that this is catastrophic reaction. We had this
Mm.
short note question in our semester exam.
So,
Yeah, I couldn't write it. I did not know it at that time, then I read it later. Okay, then we have personality changes, which is disinhibition and impulsivity, for example, which is seen in frontotemporal dementia. In
okay.
Alzheimer's and vascular dementia, most commonly it is apathy syndrome, that is, patient is amotivated and withdrawal is seen. So FTD is disinhibition and impulsivity. Alzheimer's and vascular apathy, there is amotivation and withdrawal.
Mm.
Moving on to psychosis, early there it is seen early as paranoia and belief that belongings have been stolen. And there is one more, misidentification of uh,
Okay.
of the family members. Sometimes
Okay.
they would misidentify the um, the family member from a deceased person
Okay.
to a deceased person. Son would be misidentified as some relative who is deceased, for example.
Mm.
So paranoia, uh, that it's like persecutory beliefs are there, and also believe that someone, sorry, infidelity. There's like this one is there. Infidelity is common in
Mm.
belief. Then you have stolen, that someone has stolen things, stolen belief. These are some of the very common beliefs
Okay.
that are seen. And in later stages, visual hallucinations can also occur, and these visual hallucinations are usually of deceased
Okay.
relatives. But in which case does visual hallucination is like a primary thing?
In Lewy body, that is characteristic. No?
Yeah.
Mm.
Then we have sleep disturbances, disrupted and fragmented sleep. Then we have agitation and aggression,
Okay.
progresses with severity.
Mm.
And so this could be physical or verbal forms. So patient would scream, act out, and even swear.
Okay.
Other behavioral disturbances include risk of wandering and disinhibited social behavior.
Okay.
So when
Mm.
I was reading BPSD, everything was included in BPSD
Okay. Okay.
except for hyperorality. That was like one thing that was there. Hyperorality was, it was not discussed here, but I think even hyperorality would be coming under neuropsychiatric manifestations as well.
Okay.
So okay, great. So
So there
laboratory,
is
yeah,
overlap in between textbooks also.
okay,
At least we have to stick on to one standard textbook. You might be aware of this thing, no? Like in MSc,
yeah, fish
obsessions,
and
obsessions. Yeah, in fish
yeah,
it's given somewhere. In one it's given under content, in another it's given under the possession.
yeah. So in fish it is given
So,
under content. And I
mm,
think in Sims or some other one, it is given
under possession,
under possession.
possession,
Yeah,
possession. Yeah.
yeah. So we
So
actually follow this one.
in your
Which one?
institute, mm,
Sorry?
we have to go as per our institute. Manish sir also used to say the same thing.
Acha, yeah,
Whatever is
true.
being followed in the institute, you have to follow that thing.
So
or
true, so
exams.
true.
Mm.
Oh my God. Wait, there's some issue here. Just a sec.
Okay.
Okay, okay. This one here. Cool. Okay, so assessment of dementia. So this is something I have put in between. Not actually in between. Okay, so we'll discuss assessment of dementia, and
Okay.
then we will go on to see um, we'll go on to see this part, diagnostic approach,
Okay.
um, and management, and then we'll look into Alzheimer's as like like we'll see how it goes.
Okay.
Okay, so assessment of dementia. So this is from like Code Red actually. I was reading it today.
Okay.
So these are
Oh.
their notes only, sir's notes.
Mm.
So history, examination, general physical examination, systemic, mental status, cognitive assessment. Then
Okay.
we'll see into investigations, neuroimaging, structural and functional, and instruments, and then differential diagnosis. Instruments would come under cognitive assessment itself. They have just mentioned it
Okay.
separately. So the first thing that we do is take history from the patient, caregiver, and medical records. Uh,
Mm.
Note down the social-demographics, chief complaints of the patient, total duration of illness, onset and progression of overall illness, could be acute, subacute, could be insidious, in the progression, fluctuating or continuously progressive. Then we look into the precipitating and perpetuating factors of the dementia. Then we
Mm.
go into details of presenting complaints. And in under details of presenting complaints, we also look into history of specific cognitive domain. How is attention and
Okay.
concentration affected? Are
Mm.
executive functions also affected? What about memory and
Okay.
learning, language,
Mm.
visual spatial impairment, and social
Okay.
cognition? So,
Okay.
I mean, we have read these so many times. I think now we can remember what are the
Mm.
things. If you
Mm.
remember, these are the exact things that we just discussed about in clinical
Exactly.
features of
Yeah.
dementia.
Those six things. Mm.
Yeah. Is there one thing that is missing, isn't it? I think so. Yes.
Execute
The
commanded
percept.
and language. Mm.
I think no. This one they have just written it differently. This was perceptual motor, isn't it? Visual spatial was
Language, motor.
perceptual.
Yeah. Mm.
Yeah, language motor. Rest of them are same.
The motor thing they have not mentioned.
Yeah, language motor. Cool. So, and then we go on to see the clinical features of dementia specific to each dementia. So, first we look into the domains, cognitive domains completely, and then
Mm.
we go on to look into the clinical features of specific domain dementia, whatever it is
Mm.
that you're suspecting, primary dementia, secondary dementia, and then BPSD, that is behavior and psychological symptoms of dementia. And
Okay.
we also look into the impairment in daily functioning, how much daily function has been impaired, and then rule out all other things. For example,
Mm.
reversible causes of dementia, any comorbid mental disorder, any comorbid
Mm.
substance use disorder. So this is what you're going to do in the HOPI of this patient.
Okay.
I mean, if we are going to be, we are asked like, what is the management of dementia? So this is what I formed. So the assessment we will use this one, the same thing we'll use, and we'll just
Mm.
say HOPI. We'll discuss this, and then we will also look into the past treatment history of this patient, look into the response and side effects of treatment in past, and duration of treatment, and was there any non-compliance to treatment?
Okay. Mm.
Any family history of in the patient, any medical history, any personal history significant, and sexual history is very important because sometimes, but we have already seen it here, behavioral and psychological symptoms of dementia, although
Mm.
you can
Mm.
mention it separately because sexual history comes under personal history. So
Mm.
sexually inappropriate behavior is present or not, or high risk sexual behaviors is present or not. Next, we go into the physical examination in assessment. So we
Mm.
have seen clinical features, HOPI, past treatment history, medical history, personal history. Now, physical examination,
Examination. Mm.
vitals, signs of nutritional deficiency. We are suspecting any nutritional deficiency and injury overhead if
Mm.
present. So, well, we will do the pickle. in the general physical examination. And if on general physical examination you find patient is cachectic, you can look into nutritional deficiencies or malignancies or AIDS.
Yeah.
You can suspect
Mm.
this.
Mm.
KF rings are present, Wilson's disease,
Mm.
uveitis, sarcoidosis, TB, multiple sclerosis,
Mm.
peritibial myxedema, probably hypothyroidism.
Thyroidism.
Blue, yeah, Burton's line, that is bluish gums, lead poisoning. So
Mm.
all of these are some, like, this is what they gave some examples, and you already mentioned what we can do is we can write the things that you can do. So for NPH,
Yeah.
but that will come under, this is the physical examination. NPH would only be
Mm.
looked into when we are going to do the structural examination of the patient. That is
Image. Mm.
neuroimaging.
Mm.
Okay, so this is done. I actually crossed it because I was not able to understand this. So this I
Sorry,
don't
what?
understand. What is this? Is this lymph node
Where is it?
lymphadenopathy or is it lower neutron? I don't understand.
Where is
Probably
it?
lymphadenopathy.
Can you please move the cursor on, or could you
Sure.
round it off?
Yeah, yeah, yeah. Can you see it now? Sorry. Can you see it now?
Yeah, yeah. Lung palsy, not a lung palsy.
Yeah, I was like, is it lymphadenopathy? Because usually
I
HIV
think lymph node
sarcoidosis.
palpation. I think it's
Okay, on lymph
because
node
lymphadenopathy will
palpation.
be seen in everything. No, in
Yeah.
sarcoidosis there will be deposits in HIV, in
Yeah.
TB.
Okay. Yeah,
That might be
you're
lymph
right.
node palpation.
Yeah. Lymph node palpation. Right.
Mm.
All right. So moving on, we have systemic examination. So we will do different systems examination, but very important is the CNS or neurological examination.
Mm.
So if now, what are the types of gaits that you can find in different types of disorders? So you have Parkinsonian gait, that is short shuffling gait.
So shuffling gait. Mm.
Yeah, and this could be in Parkinson's disease dementia or dementia of Lewy bodies.
Mm.
Then we have limb circumduction. That means patient has inability to flex hip and knee, and because of weakness, so they do a semicircular motion when they have to bring their leg forward. So it
Mm.
is hemiparesis gait, which is seen in vascular dementia, and it
Mm.
is probably because of the that part of the brain that is or damaged, which is in control of the limbs
Mm.
of the right or left limb. Then we have frontal gate pattern, which is magnetic gate, which is seen in NPH. So
MPH. Yeah.
yeah, do you like I was partially able to understand what is magnetic gate. Do you know like exactly what is magnetic gate that is seen in NPH?
Uh, for this, there is one YouTube video. If you search magnetic gate for NPH in YouTube, it's there.
Sure. Yeah,
Before
please share
releasing
that
the
with.
pressure, yeah, before releasing that and after releasing the pressure, I think I have seen one video regarding the same thing long back.
Okay.
You can once
Okay.
go through it. Mhm.
Sure, sure. Thank you. Can you like describe what it is?
Because they won't be able to lift their leg upwards, so they'll be dragging the feet.
Yeah, so that is why how I understood it. Like it's like their leg is stuck like a magnet.
Tuck, yeah, yeah.
So that is why it is called as magnetic gate.
Mm.
All right, all right. So they just drag it forward.
Mm.
Okay, got it, got it. So NPH, there is a triad. Can you tell me what is the triad for NPH?
No, no, I don't
Wacky,
remember.
wobbly, badly, something like this.
Okay, okay, okay.
So one is definitely gait disturbances, ataxia or gait disturbances.
Mm.
Another one I remember is urinary incontinence.
Mm.
And I think the third one is because we're talking about
Headache.
dementia.
Memory. Wait
Sorry?
a second, I'll just search and tell.
Sorry, what?
I'll just search and tell. I think it's headache or something, but I'm not sure.
I I think it's dementia, memory issues, probably. Yeah, please let me know. Like
Yeah, it's
because I think that
cognitive impairment. Yeah, it's dementia.
okay, it's cognitive impairment. Is
Gait
it right?
disturbance, urinary incontinence, and dementia. Yeah.
Okay, great.
Wet, wobbly, and wacky.
Wobbly, and wacky. So wacky
Yeah.
is because cognitive. No, there's three things: wacky, wobbly, and
Wet because of the urinary
Ah,
incontinence.
right. So wacky is because these cognitive problems, wobbly is because
Mm.
of the gait, and wet is because of the wet, wacky, and um,
Mm.
wobbly grandfather. This is how it is. Old man,
Okay, okay.
if you can remember it.
Mm.
Okay.
Okay.
Next is CNS examinations. Then say involuntary movement. So if there's involuntary movement or resting tremors, postural movements, like on changing position of the body, then myoclonus and chorea. So resting tremors can be present in Parkinson's disease,
Mm.
right?
Yeah.
And then myoclonus, sudden brief shock-like jerky muscles, could be present in, I think, Huntington's. No, Korea. Korea is present in Huntington's. What about myoclonus? I think many diseases.
Myoclone. Mm.
Example?
Uh, there is one thing called juvenile myoclonic epilepsy. I'm assuming it might be
Okay.
there.
Okay. Yeah,
Myoclonus.
let it be. Let it be. I think myoclonus would be
Mm.
present in so many, like it is like one of the features in all of these dementias, probably.
Mm.
Sudden brief shock-like jerks of the move muscles. Um, Myoclonus is also present in, isn't in serotonin syndrome, isn't it?
Mm. Yeah, that is like the differentiating feature in between the
Yeah. And
serotonin syndrome and NMS.
hyperreflexia is also present. Rather
Hyperreflexia
than,
clonus. Yeah,
yeah, and clonus, right.
the GIT symptoms will be predominant in serotonin syndrome.
Which symptoms? What do you call these?
GIT, gastrointestinal tract
GIT.
symptoms like
Yeah,
the
yeah,
diarrhea.
yeah.
Everything. Mm.
All right. Okay. Can you like look into this and let me know like where myoclonus can be present in cases of dementia and what could be the cause of myoclonus?
One second.
Sure.
Yeah, it's specifically associated with CJD,
Okay.
Creutzfeldt-Jakob disease,
Okay.
along with rapidly progressive dementia, myoclonus, ataxia, and other EPS signs are seen. And other
Hmm.
dementias like the Alzheimer's, dementia with Lewy body, frontotemporal.
Okay. Mainly in all
In
primary causes of dementia then.
exactly.
But
In other
but
neurological
mainly,
causes, sorry,
yeah. But mainly CZD and then other neurological
yeah.
causes as well.
Other neurological causes like juvenile myoclonic epilepsy, metabolic encephalopathies, Wilson's,
Right. Okay.
and even with SSRS, serotonin syndrome, as you have rightly mentioned, drug-induced
Okay.
myoclonus, that's what they are calling it.
Okay. Awesome.
Lithium toxicity, opioid toxicity, tramadol.
Right. Right.
So, but the thing is, if anybody asks rapidly progressive dementia with myoclonus, we have to tell CJD.
Okay. Got it.
Okay, okay,
Great. Thank you.
okay, Palak, I have to take leave now.
Okay. It's
We
okay.
have
Anyway,
20 something.
it's a little bit is left. I'll just read it through. Okay.
Hmm.
Great. Thanks,
Okay,
Sai, for joining in.
thank you so much. Yeah,
Okay.
thank
Bye
you.
bye.
We'll definitely be in contact in case of any
Yeah. Yeah.
doubts.
Yeah.
Okay,
Definitely. Okay.
okay,
Bye
okay,
bye,
Palak.
Sai.
Thank you. Bye, good night.
Yeah. Bye. Good night. Okay, so guys, let's continue with MSc with neurocognitive functions. Now, neurocognitive functions, we will see like what are the instruments that are used for neurocognitive functions later. Then we go into the investigation. So, in investigations, we do laboratory evaluation of dementia. So, we do the assessments and what is the reason of these assessments. So, going into labs, we do complete blood counts, serum electrolytes, renal hepatic function, glucose, albumin, protein, vitamin B12, folate, rapid plasma, reagent syphilis, TSH, renal analysis. We already discussed this. Rule out correctable or contributory cause of dementia. Structural imaging would include CT and MRI to rule out infarcts, mass lesions, tumors, and hydrocephalus. Then we have molecular and functional imaging, that's PET amyloid imaging, SPECT, fluorodeoxyglucose PET. Now remember these. So PET amyloid imaging, SPECT. So these are functional imaging, and fluoro deoxyglucose PET. So, what will they do? They will identify pathological biomarkers, that is, A beta accumulation or patterns of cerebral blood flow or metabolism that may be characteristic of specific neurodegenerative disorder. So, for example, if there is A beta accumulation, we could think of maybe Alzheimer's dementia. See, next is CSF. So CSF actually detects these proteins. So detect altered levels of amyloid beta, tau protein in Alzheimer's disease, or elevated 14-33 protein and neuron-specific enolase in CJD, that is Creutzfeldt-Jakob disease. So what is present in CJD is neuron-specific enolase. All right. So amyloid beta and tau in Alzheimer's and elevated 14-33 protein or neuron-specific enolase in CJD. There is prions disease. Now, there are some additional tests that you can do as well. This could include anti-nuclear antibody, which is done for SLE, ceruloplasmin for Wilson's disease, ESR for any autoimmune or infectious causes, anti-HIV antibody. We have lumbar puncture, routine lumbar puncture for amyloid beta, AFB, then Cryptococcus fbs, tuberculosis, IgG, IgB. So for lumbar puncture, we will be able to find out all of these things, that is infectious causes, or even amyloid beta can be found with them. So next is urine analysis. We will look into urine copper and toxicology screen. Urine copper for Wilson's disease, toxicology screen for any substance that has led to dementia. We will also do EEG in these patients. All right. So these are some of the additional tests that you would do in these patients. Now, if you remember, we went on to see neurocognitive function. Now let's see what are the neurocognitive batteries that are instruments that you can use. So you have MMSE, mini mental state examination, um, Montreal cognitive assessment, something cognitive assessment. Then you have ACE3, which is the most sensitive one. And ACE3 actually involves 5 domains. This is important. It involves attention, memory, language, verbal fluency, and visuospatial ability. Again, attention, memory, language, verbal fluency, and visuospatial ability. Um, then for severity, we have global deten- deterioration scale. All right. Now, looking into specific domains, there are following scales that can be used. So, what are the scales? We have global cognitive scale. For global cognitive scale, these are MMSE, Montreal Cognitive Assessment. So I was right. For global assessment of the cognitive functions. Then next on, we have intelligence. For intelligence ability, we have For intelligence ability, we have uh, Wechsler's Adult Intelligence Test 2 and 4. Then attention processing speed can be screened using digital spend test and trail A. What is trail A? So there are like scattered numbers or alphabets here, and then what the patient is asked to do is to join them um, in the ascending or descending order of their like consecutive order, 5, 6, then 7, and then 8. So join these. This is Australia. This is like how much attention do they have. Digit span is also how much attention are they having. The next one is executive functions using trail B. Now, executive functions is going to test your processing. Are you able to think and plan and process? So, like, connecting one, then A, two, then B, three, and C, which also is a test that's given in the MOCA. Then we have learning and memory. Then it could be using verbal, like how is verbal and how is non-verbal learning and memory. So for verbal, we use California Verbal Learning Test. For non-verbal, we use Visual Reproduction Test. So this comes under Wechsler memory test, where you are given a figure, you are shown it for 10 seconds, and then you have to draw it immediately, and then after 20 to 30 minutes. So this is how you can actually test a non-verbal memory. For verbal, you will use California Verbal Learning Test. Next is Visual Spatial Learning, Clock Drawing Test. Then we have language, that is verbal fluency text test, We So visual spatial learning, you ask them to, well, draw a clock with numbers, with all the numbers in it, and draw it for 11 minutes, 10 hours. That means 11 is the hour and 10 is the minute. So this is what you're going to ask the patient to draw. So next is, well, language. Verbal fluency test is done for phonemic language and phonemic language and semantic language. So phonemic example, all words starting with F. Tell all the words starting with F. And semantic is as many animals as you can tell. Okay. Then next is motor ability, which is tested using finger tapping test. Okay, so this is what we will be doing in the assessment of dementia. So I think this is the whole thing, and I think we can end the session here today. So just recapping what we learned here today. So we started with ICD-11 definition of dementia. We saw who introduced dementia to us and the defining features of dementia. And then we saw the pathophysiology of dementia. Using that, we actually found out what are the drugs that we can use for these, for dementia. Then moving forward, we saw the epidemiology of dementia with 5 to 6 million people living with dementia in India. And Alzheimer's disease the most common. And because of low awareness, delayed diagnosis is there, and high caregiver burden and financial constraints. All right. Then we also saw the risk factors of dementia, both modifiable and non-modifiable. Then we saw the differences between delirium, dementia, and mild cognitive impairment, dementia versus pseudodementia, reversible versus irreversible dementia, causes of reversible dementia. Demen- we also saw primary versus secondary neurodegenerative disorders, cortical and subcortical dementia, and well, all of that. And then there is a summary table which I will be sharing on the group of a Facebook group that is linked in the description section here. Then we have risk factors, which we already saw. And then, of course, we went in to see the clinical features of dementia. So, first, after discussing all the differences, the clinical features of dementia, where we saw 6 clinical features divided, and where we saw 3 clinical features: impairment in clinical domain umbrellas, functional domain, and neuropsychiatric manifestation. For in cognitive domain, we saw 6 clinical features. Under functional domain, we saw what is the difference between basic activities of daily living and instrumental activities. And neuropsychiatric manifestation, we saw around 7 of them. Then we went on to see the assessment of dementia. We took the history, HOPI, medical, surgical, and past treatment history, personal history. We did the examination of the patient, did the systemic examination, then we did the laboratory testing, additional testing of the patient, and then we reached to the diagnostic formulation of the patient. So, under diagnostic approach, how to do the diagnosis is something that you can read through, and maybe we can look upon in later. And then we can first look into the management, into the common management, or we can just look into some of the disorders first, like Alzheimer's, frontotemporal dementia, and stuff. And then we can go on to the treatment part. All right. Thank you very much, guys, for joining in. And I hope you enjoyed this video. Um, well, um, I really hope so. And if you did, well, please share it with people you think it can benefit. And also, all the best with your MRCpsych paper 2. I hope this was of help. And let me know in the comment section if there is something else that you would like video discussion on. And also, if you like my video, please give it a thumbs up, share it with your friends, your family, your colleagues, and anyone it can help. And of course, ring the notification bell so that you don't miss it more again. Give a like button and comment. Thank you very much, guys. And bye bye.